Good morning, everybody, again. Josh Burton here. Next topic, let's go pulmonary embolism. So again, let's start off with the question stem here. 25-year-old female, no past medical history, presents to the emergency department with shortness of breath for the past 2 days. Reports using oral contraceptives. Vital signs reveal a heart rate of 120 beats per minute. Blood pressure is 123/80. Oxygen saturation about 90% on room air. She's got crackles at the right lung base. There's no wheezing. Her right leg is also more swollen than the left leg. What is the next best step in management? Patient has a whole slew of risk factors for pulmonary embolism. Looking for a CT pulmonary angiogram. All right, let's dive in here. Epidemiology. When we think about pulmonary embolism or venous thromboembolism, those sort of things, we always think of Virchow's triad, right? Or Virchow's triad, however you want to say it. Venous stasis, hypercoagulability, and some sort of injury to the vessel wall, right? So in your question, Sims, look for those risk factors. So one leg's bigger than the other leg. Think of a DVT. Obesity, prior DVT, or pulmonary embolism, immobility, prolonged bed rest, pregnancy, some sort of cancer, chemotherapy agent, something to that effect that says, okay, we're going down Virchow's triad pathway, start thinking about venous thromboembolisms. Pathophysiology. So typically, most of these blood clots will originate from the pelvis or the lower extremities. They come on up, they cross over, they go into the lungs, they get stuck, and then they cause a pulmonary embolism. Most common cause of death, right ventricular failure. So this isn't like a respiratory failure, dear. This is heart failure. A good thing to differentiate when you're going through pulmonary embolism questions. How will these patients present? So dyspnea is the most common symptom in a pulmonary embolism. Remember in the aortic dissection lecture, most common symptom was chest pain. Here we're talking about shortness of breath. So pulmonary embolism, shortness of breath. Patient may also have hemoptysis. They might have a pleuritic chest pain. They might have syncope, cough, and there could be hemodynamic compromise. It could be hypotensive, tachycardic, hypoxic, and so it depends on how big the clot is, depends on how bad or how much of a change you'll see in those vital signs. On physical exam, the classic kind of progression of your vital signs that you'll see is someone who's tachypnic, someone who's tachycardic, and someone who is hypoxic. Obviously, this doesn't feel good, and so they're going to be sweaty, they're going to be diaphoretic. Look at their lower extremities. They could have lower extremity edema, one bigger than the other. Could be some cyanosis, and again, if this is a massive PE, then you're looking for signs of shock, and if they're hypotensive. When you're looking for like what to clue in on like a test question, there's two rules that come into play a lot with pulmonary embolism. One is the Wells criteria and one is the PERC rule. I've seen this come up on a couple like Roche review questions and other Q banks. I'm not saying to memorize all of these, but it's good to be aware of how each one of these are used and how you can kind of use these to answer the questions moving forward. So think of the Wells criteria as something that rules in a PE, and think of the PERC rule as something that rules out a PE. Going through the different things that are included in each one of these decision-making tools. You know, in a Wells criteria, we're looking for clinical signs of a DVT, a fast heart rate. You know, PE is the number one diagnosis, or equally likely saying that, man, I really think it's the PE. Let's kind of go down that pathway. Different than in a PERC rule, when we say, man, the patient is, you know, not greater than 50, their heart rate's okay, their oxygen's okay, I don't see any unilateral leg swelling, I really don't think this is a PE, and what else can I add to the chart to say I really don't think this is a PE? That's where the PERC rule comes into play. And so knowing the difference on management and how you use these scores kind of help determine, am I going to go to a CT pulmonary angiogram as my next step? Am I going to get a D-dimer? Or do I just don't think this is a PE at all, and this is a low-risk situation scenario? So going down that pathway, so the next step would be talking about labs and evaluating the patient. So if you think there's a pulmonary embolism, you do a diagnostic prediction model. You say, okay, this patient's of low risk. I'm going to get a D-dimer. There we go. If the D-dimer is negative, then that's enough confidence to say most likely not a PE. If it's positive, then we're looking towards making the diagnosis, looking for a CT pulmonary angiogram. And again, if the patient is high risk, then we bypass the D-dimer altogether and we go straight towards the diagnostic tool being a CT angiogram with PE protocol. So that's how the D-dimer works. And so if there's someone in a question sim that's low risk, low to moderate risk, you're looking for that D-dimer as a rule-out test to be used. The other labs that might come up into play when you're going through these question sim is a troponin and a BNP. And it could be the simple question as, what's evidence of right heart strain, of the following options or whatever it may be. You're looking for a troponin and a BNP. So again, remember that the most common cause of death is heart failure, right heart failure. So we're looking for stress on the heart. That's a troponin and a BNP. Next things to look for that would coincide with that would be an ultrasound. So again, in the emergency department, we love point of care ultrasounds. So other evidence of right heart strain that they might clue you in on. If they describe, septal deviation or right ventricular enlargement, something to that effect, trying to clue you in on, there's strain on the right side of the heart, we're trying to get you to a pulmonary embolism. They either might describe this or show you a picture of a bedside ultrasound. And this is what it looks like. So this septum here typically should, not be deviated that much, kind of more over on this area here. But in this situation, you're seeing how it's pushing into the left ventricle, whereas typically the left ventricle has much more pressure than the right, and it should be the opposite case. Moving forward on evaluation, chest x-ray, there's a couple pearls as far as test questions go with a chest x-ray. The first one over here on the left is the Hamptons Hump. They might show you a picture of this. It might just be described, but what you're looking for is a triangular wedge-shaped density on a chest x-ray with the rounded apex that points towards the hilum. That's Hamptons Hump. That's saying, hey, we're trying to get you to a pulmonary embolism. The next one is Westermarck sign, where you see lung markings here and then you don't. So you have this dilation of a pulmonary vessel, it's proximal to the embolus, and it's associated with regional oligemia distally, or kind of loss of these of the lung markings here. And that's what's called a Westermarck sign. Seen it both where you get a picture or it's described to you. So Westermarck sign, think regional oligemia. Hamptons Hump, think triangular pleural-based density. We're trying to get to a pulmonary embolism. Next up on evaluation that you might see would be an EKG, right? So left to right axis deviation can occur. A right bundle branch blocks, and that you see here with these RSR waves. And then the classic S1Q3T3 abnormality, which for a long time I thought only existed on board questions, but in reality I've seen it multiple times in the clinical setting. And so keep an eye out for it and look for it both clinically and on the test. So you're looking for that S1 wave, the Q wave in lead 3, and the T wave inversion in lead 3 as well. Another sign of right heart strain on an EKG would be T wave inversions. So if you're looking for T wave inversions in the inferior leads, what you see here, or on the anterior septal leads in V1, V2, V3, V4. Again, that's a lot of clues saying, hey, the right heart is being strained. Let's correlate clinically and see if this is a pulmonary embolism. Two different types of imaging, right? So pregnancy always comes into play. That's a risk factor. What kind of imaging are we looking to do? First line would be a color flow duplex ultrasound. And then the second would be a VQ scan as far as being the diagnostic test of choice. For everybody else, what we're looking for is that CT angiogram with PE protocol or CT angiogram for pulmonary embolism, and you're looking for that blood clot in the saddle there, which is this right here. As far as management goes, there's a lot of debate and research and things going into as far as when can thrombolytics be used and can they be used in other scenarios besides cardiac arrest and shock. For the purposes of the test, I think we're looking more for black and white answers here. And so think thrombolytics if it's cardiac arrest or shock. So if this is a PEA arrest again, or if this is someone who is unstable because of clot burden, thrombolytics is most likely going to be your answer. And then if they're stable, looking for anticoagulation. So we'll keep it real easy there as far as management goes. Again, if you want to dive further into that topic, there's loads of things that you can go and learn about. But purposes of the test: cardiac arrest and shock, think thrombolytics; stable patient, think anticoagulation. All right, let's practice. Review. Question number 1, what is the most common symptom of a pulmonary embolism? So again, dyspnea, chest pain, hemoptysis, syncope. Covering that before. Dyspnea being the most common symptom for a pulmonary embolism. Chest pain for that aortic dissection. For some reason, they love these tests, these questions on the test, you know. Question number 2. So a 25-year-old woman presents to the emergency department with chest pain. Symptoms have been present for 2 days. She takes oral contraceptives for birth control. She reports cough with hemoptysis, vital signs within normal limits. She otherwise appears well. What is the next best step to evaluate for a pulmonary embolism? So this is that situation where I was saying, hey, you know, is this a low-risk patient? Is this a high-risk patient? So, you know, go through the question stem and, you know, what kind of picture are they trying to paint? You know, this patient otherwise appears well, vital signs are normal, has some risk factors, but otherwise is doing okay. Low risk, but still has enough to say, is this a pulmonary embolism? That's where that D-dimer would come into play, versus going straight to the CT angiography. Next question. So a 55-year-old male presents to the emergency department with chest pain, complains of sudden onset pain that is worse with deep breathing. Right leg is larger than the left. Big clue. Vital signs: hypotensive, tachycardic, oxygen saturation 90%, tachypneic 24. Point of care ultrasound reveals an enlarged right ventricle. As you're examining the patient, he becomes unresponsive. What intervention is indicated in this patient? So again, shock, cardiac arrest, going for the big guns, IVTPA. All right, guys, that is all for pulmonary embolism. Thank you.